Good evening, everyone. My name is Dr. Bill Tulo, Medical Director for Oculus, and welcome to Orthokeratology with Pentacam and Wave, Efficient and Accurate Custom Lens Design and Treatment by Dr. Ken Maller. Dr. Ken Maller earned his doctorate of optometry from the Illinois College of Optometry. He immediately entered private practice and is currently in private solo practice in Fort Lauderdale, Florida. While in private practice, he also participated as a clinical investigator for multiple clinical studies regarding contact lens and contact lens solutions. He has many articles published, authored the first Wave Contacts Designer Certification Program, and has lectured extensively. Dr. Maller is a member of the American Optometric Association, the Contact Lens and Cornea section, the Contact Lens Society, and a charter member of both Orthoke.network and the Orthokeratology Academy of America. He's on the advisory board of the Gaspermeable Lens Institute, a fellow in the American Academy of Optometry, a fellow in the International Academy of Orthokeratology, and a fellow in the American Academy of Orthokeratology and Myopia Control, and also a fellow in the Scleral Lens Education Society and a diplomat in the American Board of Optometry. Most recently, he has earned his diplomate in the Cornea and Contact Lens and Refractive Technology section of the American Academy of Optometry. And it gives me great pleasure to welcome Dr. Ken Maller. Ken, it's all yours.
Thank you very much, Bill, and welcome to all of you attendees out there. Tonight we're going to be talking about Orthoke, the Pentacam, how it can be used for Orthoke, and how all that data can be fed into Wave, so we can design some fantastic orthokeratology treatments that often really can't be designed through any other methodology or any other lens designs that are currently available. Let's see if we can get this on. On this first slide up over here, down at the bottom, that is my office address in Fort Lauderdale. And for many who already know, I do consultation, private consultation for many of the Wave docs that are out there. Some of you maybe even possibly. But if anyone is interested in obtaining any of my help for any of that, you can just go to my website at that consultation address there. That's down at the bottom of this page. All right, so let's go ahead and get on to Orthoke, custom designs, and what we can do. But let's get the housekeeping out of the way. I am consulting for Oculus now, helping them to try and get Wave and Pentacam to play nicely together and really expand out how efficiently these two sort of independently grown-up platforms are going to work together. But first and foremost, I'm a fitter. I'm in the trenches every day, and I deal with eyes every day. It's a contact lens only practice. I'm by myself, and pretty much the entire practice is messy corneas, and anyone who doesn't have a messy cornea, and maybe even some of those messy corneas, end up in Orthoke. Previously, I did some national support for Wave back many years ago on a case-by-case basis. I've done lectures for Wave through formal instructional methods, and as I said, I do private case-by-case help or one-on-one training. I fit remotely. Many docs out there through telemedicine. Sometimes cases end up a little bit tough, and they need a little bailing out, and I'm happy to help them out for that. I also have done extensive beta testing, both for the CSP software and the Wave software. And Bill said I did author the first Certified Wave Designers program, and currently I'm helping out with the forward movement of Oculus and Wave together. So let's start first with the Pentacam. I don't know if everyone out there has a Pentacam, but what is it? Well, it's basically a camera that spins around and takes some pictures by slicing through the ocular tissues. Of course, not literally, but just with some wiring. But it does give you some fantastic data, both on the surface as corneal topography, as in addition to the cuts of tomography and imaging out the anterior segment. There are 3 units, the basic AXL and HR. For the purposes of Orthoke, all 3 of these are perfectly fine. For anyone who's using CSP software, the basic is probably the one you would want. The AXL is not compatible And the HR, it is compatible, but it does take considerably longer to process the data. So for those who, in addition to Ortho-K, are fitting scleral lenses, the basic actually is fine. But for Ortho-K and you're sitting on the cornea, all three of these are fine. So Ortho-K, what is that? Well, we're intentionally and temporarily reshaping the cornea with a contact lens used on some repetitive schedule, which is most recently really moved to an overnight schedule. But some of the old timers like myself used to do, and on occasion will still day wear Ortho-K. But the intention there is to induce a change to the refractive status of the eye. It's been around for better than 60 years. Ortho-K reduces eliminating myopia. The FDA has approved that from -1 to -5 prescriptions. Now, reducing or eliminating astigmatism. The FDA has also approved that up to 1.5 diopters of cylinder. Reducing or eliminating myopic progression. The FDA has approved that from -1 through -5. All right, Wave, what is that? Well, basically, it's just a graphical software interface. It allows the lens designer almost total control of virtually every aspect of the design and manufacture of a rigid lens. You can use it two ways. You can model from a theoretical surface, so you can create an artificial theoretical surface by feeding in a simulated cornea, or you can actually model from the actual data that's collected off the surface of the cornea. And we're going to primarily be talking about that today. You can design single vision, multifocal, corneal lenses, scleral lenses, Ortho-K. It's all possible to do. Anything you can do with a rigid lens, you can do on Wave. But it's important to understand Wave is not a lens design. It's not a laboratory offering. There's no predetermined or testing fitting guide or anything like this. You have to understand when you start with Wave, you really are on your own. You have a blank canvas to design anything you'd like. And although that does bestow a great deal of power in your hands, it also allows you to go off the rails very easily too, and you end up designing a very complex piece of plastic garbage that doesn't do what you want it to do at all. There are a couple of software platforms that have started to hit the market. Wave by far is the most mature of all the software platforms in this arena. All right, so let's get into the nitty-gritty of Wave. Corneal and scleral surfaces are not rotationally symmetrical. Anyone who's been doing topography or scleral profilometry already knows these surfaces are not rotationally symmetrical at all. E values vary across each of the radii, and that does create problems for some of our lenses, whether it's decentration or digging in or tilting or whatever. Those are all problems. The way Wave deals with that is it divides the lens, the 360 degrees of the lens, into 24 discrete segments that are each 15-degree pi wedge segments that are wide around the clock. It further divides each of those 15-degree pi wedge segments into 88 zones from the center of the lens out to the very edge of the lens. And by using the topography of the patient as the guide, you now have the power to control each of those 88 zones of each 15-degree pi wedge segment. Wave takes care of the housekeeping by making sure each segment connects to the segment next to it, so you have a smooth transition going from one segment to the next, so you have a smooth surface both on the front and back surface of the lens. So diagrammatically, to show this, here's the red. If we have this as a contact lens, and we were to say what would a monocurve lens look like, we could take this red curve to represent a single monocurve lens. You'd have a single curve from any spot on that. So you can measure it and it would all have the same curve. However, this is what Wave is doing. You can see there from 30 degrees to 45 degrees, that's a 15-degree wedge, and that's one of the 24 that go all the way around the clock dial. And then over here where I have the hash marks, white and red alternating, those are 88 sections. And so each striation that you're seeing there, red and white, represents one of those 88 zones. And so you have control over all of that all the way around the clock dial, both on the front and back surface of the lens. Wave just connects them all together so you have a continuous surface. So you have a little over 2,000 areas that are under wave's control. So because you have that, you really can align the lens very, very well with the cornea by manipulating the back surface of that lens. Now, since wave is understanding what you're doing to the back surface at any given location there where those segments are, it can calculate compensatory powers for the front surface to create an equivalent area on the front surface to neutralize that out, so it works like a gas perm lens is supposed to work. The complex construction can be used to design basically everything: corneal sclerals, multifocals, orthokeratology. And when you design these lenses, you really don't design in thinking in terms of base curves that are rotationally symmetrical, but rather you think more in terms of tear layer clearances between the front surface of the cornea and the back surface of the lens over any given area there. All right, so let's get into a couple of cases here and how we can apply all of this. This is case number one, 12-year-old Asian male. His glasses prescription is a year old. He's about a 250 myope, and you can see he's had a little bit of advancement in the myopia. He's up at 375. Now in the right eye and 3 1/4 in the left eye, almost no cylinder. Health is good. He's got nothing, no allergies. The rest is kind of boringly normal. No contact lens history. And the parents who brought him in specifically brought him in for Orthokeratology to control the myopia. So here's an overview screen on the Pentacam. And I know some of you aren't familiar with this, so I'm going to just kind of describe a little bit what we're actually seeing here on this screen. You can see in the upper left there's the R, and that's the actual image that was captured by the camera. And the blue bar is the section that you're looking through. Down just below that, you can see that the 20 out of 25 is circled. The Pentacam takes 25 slices as it spins around, and we're looking at slice number 20 out of the 25. The little dot that's on the left side there, that of course is on the temporal side of this right eye, you can see in the cross-sectional view, the dot is on the left, so you have orientation, you know what you're looking at on the cross-sectional image there. Over here, you see that dotted line crossing through the visual axis, and you can see on the right, I have it pointed to that raised up green area. What that is basically a transmission of light. So anything that interferes with light making its way through some particular surface registers on that green graph there as something interfering with the light transferring through unencumbered. The higher that number goes and the higher that peak would be on the green graph there, the more opacified whatever structure the light is passing through. You can see there where the yellow horizontal line is, and that's the lens. The green on the right is raised up a little bit, and that's just telling you that the lens is absorbing just a little bit of the light as it's passing through those surfaces. That's actually very helpful in following any opacities that are located on the cornea through time, because you can put that dotted line right through the opacity, and you can see if it's actually become more dense or less dense than the last time you had measured it. Down at the bottom, that's just a graphical show of what we're seeing on the top, and on the left side there, you can see that you can check or uncheck any of the spots that you want to see. You can have it as a gridded display where it just is show, or you could fill it in, such as where you see the red, the green, the blue being displayed for the entire surface. Up on the upper portion of the cross section, you can see the red is the anterior surface of the cornea, the green is the posterior surface of the cornea, the blue is the iris, and that image down at the bottom is actually an image you can grab and spin around so you can see it from different angles as you see fit. Over here on the upper right, you have the simulated K readings that it measured off the front surface. And it's telling you here in this particular case, it's 1.9 diopters of astigmatism. QS is a quality control value, meaning that you were able to, this actually was a good capture that we're basing our interpretations on. And if we come down up over here in the lower right, that's a graphical, colorful display. And this is showing the tangential front curvature, but you actually have a drop-down menu there, and you can choose any of those particular displays to view depending on what you might be interested in seeing in terms of data. So this is really a good overview screen of the eye. It gives you a good sense of what kind of eye you're dealing with. So coming up over here, this is the refractive screen, and it's divided into just a couple of sections. I just want to quickly go over these. You have the front of the corneal surface, so you can see there the simulated Ks and the equivalent radii that's next to those. You can also see, again, the stigmatism that's between those two. The next box down below is the back surface. Anyone who's been working with only anterior corneal topographies, this is going to be a little bit more foreign to you. You're not accustomed to getting data off the back of the cornea, but it's basically the exact same data you get on the front, but it's just off the back surface of the cornea. So you've got simulated K readings, again, how much cylinder is on the back surface and the like there, and the radii of curvature as well. Down at the bottom over here, and in the lower left of the four colorful graphical screens is pachymetry, where you're measuring corneal thickness. You can see here that it does give you a thinnest local point of 587 on this particular eye. And there's a couple of numbers spread out over the display. However, if you do use your cursor there, you can get a measurement of thickness everywhere that the cornea was measured, not just at those particular points. So it's a 100% pachymeter over the entire surface of the cornea that's measured. The bottom there gives you cornea volume as well as the horizontal white-to-white measurement. And the pupil, this one here says it's 11.4 millimeters, and it also gives you the pupil diameter as measured at 2.66 millimeters. The upper left, that's the closest thing that would be to a Placido disc anterior surface curvature map. It's the axial sagittal curvature of the front of the cornea. And of course, you can see that this cornea has a little bit of cylinder. On the upper right, you have the elevation of the cornea. You can see it's very, very normal cornea. There's nothing unusual about the elevations here. The lower right is the back elevation of the cornea, and that is actually a very important screen to see if there's anything unusual going on the back. And moving forward here, I've just put up the basic displays so you could see the right and left eye of this particular patient that I had. I've circled the simulated Ks and the astigmatism on both of these eyes, and we could see that the white to white is 8.4 on the right, 11.4 on the right and 11.3 on the left, and the pupil is about 2.5, 2.6 millimeters there. So that's good correlation. So what we're going to do is we want to use WAVE. We want to take all that data and design up a lens. So this is what the WAVE screen looks like when it comes up. Those are two separate WAVE screens, one for the right and one for the left, which can be identified by the big R and the big L that you can see in the lower half of the graphic screen. And I've just overlaid that right on top here. And the way you do that is there's a drop-down menu off the Pentacam screen where it says external software, and it'll say export to WAVE, and it takes that top graphical, the anterior surface data, and exports that to WAVE to create the WAVE reference screen so you can design a lens around that. Down at the bottom over there, you could see on the WAVE screen that's gray, that's the cornea. And that cornea is not just a pretty picture, but that actually is being generated from the data that was just fed to it from the Pentacam. So that is the actual shape of this in cross-section just being shown in the WAVE screen. The blue thing that's sitting on top of it is a default lens. It just puts a lens right on there. I haven't done anything to design anything yet. That lens picture is also not just a pretty picture. That's actually a cross-section of the lens from the data that's fed directly to the lathes to construct this lens. So that is actually what the lens would look like should you be able to cut the lens off into that particular cross-section. On the top half of the screen there is a graphic relationship so you can see how the lens relates to the underlying cornea. At the bottom there's a green line, and on the just above it is a black line. The green line is representing the cornea as a flat line for reference, even though obviously the cornea is a curved surface. And the black line is the lens back surface, also in reference to the green line as a flat surface, even though it obviously is a curved surface. Now here I've designed up a pair of Ortho-K lenses, and you can see I've altered the black line on both of these considerably. It's not straight any longer parallel with that underlying green line that was there. And so let's just take a look at that. I've set the diameter of these at 10.8. We had a cornea of about 11.3, so this was about 0.5 smaller than the horizontal white-to-white measurement, so 10.8. You then have in the upper right of the wave screen a quad view that has 4 pictures there. The upper left is the front surface of the wave lens. The upper right is a theoretical sodium fluorescein display, which is very accurate since it has the underlying surface that's been taken directly from the Pentacam data, as well as it knows what you've just done to the back surface of this lens. So that is a very, very accurate representation of what the fluorescein should look like. The lower left of the quad view is a back surface measurement of the wave lens. And then on the lower right is the representation of the cornea, except that it's in the wave screen. So we have something for reference, and we can see how the data is being represented from the actual raw data that was collected on the Pentacam. You enter the spectacle RX. You can see here I entered in the 3 1/4 minus the half that was sitting on that left eye. Those are 3 boxes to check off and decide what type of lens symmetry you want. R is for RSIM, G is for GSIM, and F is for freeform. I have selected GSIM over there for these particular lens designs. It does display a base curve down at the bottom there. You can see that it does give a value for the base curve, and the reason that that value is over there is that I have designed basically a spherical base curve in the center of this lens, even though the mid-periphery and periphery is not spherical. It also gives you the lens sagit at the lens edge. And if you do a mouse click anywhere on the upper screen, you can see you have several pieces of information that are given to you. At number 1, that's where I've clicked. So I've clicked through the reverse curve in that one little segment. Number 2, it's telling you where you are. So you're at a chord of 5.52 millimeters, and it's telling you that there's also 47.1 microns of clearance. Number 3, you can see the fluorescein screen, and there's a gray bar that's going to the right on the radar screen there, and that's because that's the actual spot that you are on this lens that you're checking. That radar can spin around, and you can then check this in, around the entire lens. Number 4, it puts the gray vertical line there as well to show you exactly where you are between the lens and the cornea, and you can see you're right through the reverse curve. You can actually see a little space there where the reverse curve is lifting up off of the corneal surface. And number 5 gives you a summary of the data at that spot, and so you can see that the tear layer is 47 microns. The lens sagittal depth at that exact spot is 473 microns, and you're at a distance from the apex of 2.76 millimeters, or half of that chord, which was 5.52 millimeters. You get a lens summary down on the lower right, and on this case here, you can see the initial data that I designed the lens from, and when I did the 1-month follow-up, you could see on the bottom there, I didn't happen to, on this case, take a Pentacam follow-up, but you can see on the Placido disc-based topographer at the bottom there that he did very, very well. All right, so let's go to case number 2. This was a 10-year-old white female. Spectacle RX was a year old, 3 1/4 in both eyes, a sphere. Manifest refraction is 350, so really hasn't had that much change, quarter diopter in a year, which really wasn't too bad. Everything else was very normal, but the parents were specifically interested in Ortho-K. So we put up here the initial 2 scans that were taken from the Pentacam. And on this screen up over here, you can see the right with the, of course, the appropriate data that's displayed on the left-hand side of the screen there. Again, it's a very normal, very healthy cornea. I designed up a wave lens. Over here, this one I did do the follow-up with the Pentacam scan, so you can see at the 1 year, On the left, that is, the date was November of 19, and you can see the treatment map over there. The B panel, the one in the middle, that was from October of the 18, which was the raw data that we designed the lens from. And then you can see a difference map in the lower right there to see how treatment has gone. And of course, they've done very well. You can also do this where I put both the right and left on the screen. The right treatment maps are the first column, A and C. The original maps were B and D. And then in the upper right there, you can pick and choose how you want to display which subtractive maps there is being shown. So in this particular case, I just did the right eye from A and B, and we can see there's the treatment map. So done very, very well. Okay, now this is a really interesting case. This is the third case that I want to present tonight, and the last case that I'm going to be doing. This is a 14-year-old white female, born in '88, and this goes back to 2003. So this is an old-timer case. This was 18 years ago. She came in with her glasses broken. Uncorrected vision was 70 plus in each eye. Manifest refraction, 2.5 diopters in the right eye, only 1 in the left eye, but a lot more cylinder in the left eye, and only got to about 20/25 minus. I got the impression that she wasn't really a very habitual glass wearer. Even though she didn't see all that wonderfully, I think she wore it when she felt like wearing it. Anyhow, everything else was very normal, nothing unusual going on with this particular 14-year-old, and so I gave her a pair of glasses and sent her on her way. She came back 3 years later. She's 17 now. This is 2005. She broke her glasses again a week earlier, and she's had no problems with the glasses that were from when she was 14. Her vision in the right eye dropped a little bit down to 2100, and even a little bit less of a drop in the left eye. You can see the manifest refraction, though, isn't really a lot different spherical equivalent. We now have much less cylinder. There's only 75 and 1 diopter in the left eye. But that's been added onto the sphere. So spherical equivalent, she's about the same amount of myopia, but had decreased cylinder. I'm not really clear as to why that was. Again, nothing unusual about this, so I updated her pair of glasses once again in 2005. She showed a little bit of interest in contact lenses, so I said, sure, we can design up some lenses for you. And I talked with her about soft and gas perm lens. She was 17 years old. And we decided to go ahead with a pair of gas perm lenses. So you can see the simulated Ks showed about 1 diopter of cylinder, so that kind of went a little bit more with this refraction than the one we had a few years earlier. And you could see that the right eye looks boringly normal. The left eye has those 2 little red spots there. Not really sure what that was all about. But again, nothing really unusual about this particular set of eyes. So I fit her into those lenses in August of 05. She did very well. She had 20/25 minus vision, which was the best she had gotten prior as well. And so she was a happy person. So she comes back in 06, which is what, 8-9 months later. No CL wear times 4 days because she broke her left lens. She wasn't really having any problems, but noticed her uncorrected vision had dropped a little bit further. Now it's 2400 and 2100 minus. Refraction, though, looks about the same as it has all along. It's still about the same spherical equivalent, and she was able to even get to 20/20 minus. Maybe wearing the gas perms have done a little bit to get her slightly sharper acuity. Again, nothing unusual as far as the meds, and the remainder of the examination was non-contributory, and she really hasn't had any myopic progression either. So, but we discussed Ortho-K as an option to her gas perm wear, since she already broke her one lens. You can see the sim Ks again, and now the left eye actually looks more boringly normal than it did originally when I originally fit her back in 05. Again, we have about 1 diopter with the rule cylinder in both eyes from the sim Ks, but they're basically just a little bit on the flat side, but boringly normal. So let's just summarize. Okay, so back in 2005, she was -3, -75, axis 180 in the right eye, and now she's -250, -75, axis 180. I'm not really clear why she reduced in myopia, but she did. The left eye, the 175, the 1, that one's come up a little bit to 2.25 -0.5, but again, she's dropped in the cylinder. I'm sorry. If we look at the SIM-Ks, you can see incredible correlation there. The right eye is virtually identical. It's off by 1/100th of a diopter. And then the steep K is off by, what is it, 6/100ths of a diopter? So those are virtually identical measurements. And then on the left eye, okay, so we had maybe about a 1/4 diopter on the flat K and a little more than a 1/4 diopter on the steep K that's changed. Again, the orientations are virtually identical. So a cornea has been very stable, nothing unusual going on, and her refraction has been spherically equivalent, very stable, even though sometimes the cylinder is higher and sometimes it's lower, and I'm not really sure as to why that was the case. So these were a difference map that I did from the earlier to the current, both for the right and for the left. And we could see that the upper maps that I did in 06 there, on the upper left of both of those screens there, those actually look more normal now after she's been wearing the gas perms for about 9 months, 8 months. So here are my Ortho-K designs that I did back in May of 06. I used the 250 and the 2 1/4 with the 3/4 and a half diopter cylinder. And coming back a couple of months later, you can see here our uncorrected acuity was 20/25 plus in both eyes, and the maps look great. There's nothing really unusual about those. Those look fantastic, and she was thrilled with her results. So in 2006, that's the top maps over there. She was 20/25 plus. 2 years later, she came back in. Her uncorrected vision was still 20/25 plus, and the maps look basically the same as they did before. A little unusual there on the left there in the upper temporal section there with the reverse curve. Who knows, maybe she had an oddball night. But again, still doing exceptionally well in 2008. So plan, we'll go ahead and just replace her lenses. They're a little old, and maybe that accounted for why the left eye looked a little unusual. Okay, so now in 2016, she's 28 years old. She's been in Ortho-K for 10 years, and her lenses are 2 years old. The upper maps are going back to the 2008 scans that I took, and the bottom one is the 2016. And once again, we could see it looks basically about the same. The right eye showing that little bit of a yellow blip over there, but her lenses are a couple of years old, and her vision was down a little bit. So lenses are a couple of years old. I figured we got a little bit of refraction maybe coming from that little yellow blip that's down in the inferior part of the treatment zone there. And then the left eye is showing a whole bunch of cylinder that got her to 20/20 minus. Again, the map doesn't look really that odd, so I attributed some of that stuff to the age of the lenses. So we go ahead, and what are we going to do with this? So we're going to go ahead and run out a poll to you guys out there. What would you like to do? I'll give you about a minute or so to answer that.
Dr. Mallow, while we're waiting for the poll to filter in, just want the audience to know if you have questions about anything, you can put them into the chat box. And when we conclude the lecture, we'll go through all the questions. Okay, our poll is...
I see it's doing well, getting a good response out there.
Okay, let's close the poll.
About 10 more seconds there for the poll. And looks like about 2/3 of you had voted. Okay. All right, you can go ahead and close up that poll there. All right, so looking at the results of what you said out there, 2/3 of you would just replace the lens with a duplicate pair. 11% said that we should really go ahead and change the lens design because we do have that refractive error there. So we probably need to alter it a little bit to address the change in the apparent prescription, blowing off the fact that it's 2 years old and maybe that might be artifactual. Maybe it's actually a real change. 17% do some additional diagnostic testing. I didn't put in the poll as to what to do that is, but that's 1 in 5 who would have done some additional testing. And 6% would have actually discontinued Ortho-K. which I do find interesting, since she's been successful for 10 years without any complaints. Okay, so let's go on and see what I did. What I did was exactly what 2/3 of you said, is I just duplicated the pair and moved on with mine and her lives. So let's get this forward here. So she comes in 18. She's now 29 years old. The duplicate pair now is about 1.5 years old. She's been in Orthoke now for 11.5 years. And we can see here on the top, that's the 2016 maps, and down on the bottom of the 2018 maps. And we can see that her uncorrected vision today, even though that little yellow blip at the bottom looks a little bit worse centrally, she's actually seeing better today than she was back 2 years earlier with her uncorrected vision. And the left eye looks very, very normal as well. We can see here refractively, very little going on. The right eye showed just a tiny little bit of cylinder, no improvement in the acuity. And the left eye, again, a little improvement in the acuity, but it's off by 3/4 after a minus. That's a lot of minus to get maybe another letter or two. So what would the plan be now? Well, we duplicated those lenses as well. She comes in 31 years old. She's 14 years into Orthoke. These lenses are now 2 years old. And we can see now that there's something very definitively odd about the right eye centrally. It's got a little red blip now, what was a little yellow area there. And we can also see the acuity is not bad. It's dropped from 20/25 minus to 20/30 plus, so maybe a letter or two. So it's not a whole lot worse. But she was a little bit more vocal about the fact that she was having trouble seeing out of her right eye, and I can easily see why. So that day, we went ahead and did a Pentacam on her. And lo and behold, we can take a look and see that centrally, she's got corneas that are somewhat thin. They're 457 on the right and 466 on the left, with the thinnest point of pachymetry on the right eye showing at 435. Left eye was 454. Very, very thin corneas. On the enhanced ectasia display, we can easily see that she's way out of the norm in terms of the percentage thickness display that's in the lower portion of the Pentacam screen, especially on the right eye there. And if we look at the back surface of both of these corneas, we can see the left one, not so much. It's got a little bit going on there, but the right one definitely has some changes that are going on the right eye that are significant. So here, after 14 years of Orthoke, we got keratoconus, diagnosed at 31 years of age. And again, just to refresh people's memory, this is what she looked like back in 06. I doubt anyone of us here would have looked at these anterior surface maps and said, oh, well, that looks like keratoconus. So we had a manifest refraction. It was 2.5 diopters. She got to 20/20 minus. She is not an eye rubber. She no allergies or anything like that. The maps look good. Her simulated Ks are a little on the flat side with 1 diopter with the rule cylinder. And it would have been interesting back in 06 to have had rear surface information, but unfortunately I didn't have the Pentacam back then, so I wasn't able to actually take that. But this really underscores something that's very important, that, you know, here's a 17-year-old, which we typically think of as really past that super risky point of myopic progression, and certainly the risky point of where we would see keratoconus already starting to manifest itself. And yet, for the next 10 years, there really wasn't anything that would have tipped anyone off to that. And so since Orthoke is becoming much more commonly done in the young population, I think getting rear surface corneal measurements, such as the Pentacam can give to you very easily and quickly, becomes really much more vital to screen a lot of these patients before we put them into Orthoke. So to conclude, the Pentacam provides excellent source topography data to design Orthoke lenses using software like Wave. It captures data over a greater chord than is possible with the Placido disc. And additionally, if you have the CSP software, you can get all the way out onto the sclera for scleroprofilometry. The Pentacam doesn't measure reflected curvature data such as the placido disc-based systems. It's measuring true corneal elevation data. And as such, tear film quality is not an issue for collecting data, which is an enormous benefit for this instrumentation. It provides data manipulation and display screens to effectively follow Ortho-K treatment over time, and you get a wealth more corneal metrics during the Pentacam scan than just anterior surface topography, as we saw in this third particular case. So we're open for questions, and I'm looking forward to getting some good ones from you guys out there tonight.
Well, Ken, we got some good questions coming in. Great presentation. Thank you so much.
Thank you.
Our first question is kind of right along the lines of what you were just talking about. It says, could you please comment on the differences between wave corneal Ortho-K fitting with the Pentacam tomography versus the keratograph topography?
The keratograph?
Yes, keratograph versus Pentacam, the difference in fitting wave lenses with the two devices.
You can fit wave lenses with both. I've worked with the keratograph. I don't have a keratograph, but I've worked with the keratograph software and data. And although you can design up a wave lens with the keratograph, and I don't know that you get much difference in terms of actual design, I think both in initial design thought process as well as following Ortho-K, you get way more information from the Pentacam than you do the keratograph. So that's not to say you can't do it with the keratograph, but I think you're just in a much better position to evaluate a case start to finish in every which way that you can, utilizing the Pentacam data versus the keratograph data. And again, the keratograph is all anterior surface, so you're not getting any of the posterior surface, corneal surface data.
Yeah, I will add to that, Ken. I've used both machines with doing Ortho-K, and I think the only disadvantage, and it's not a big disadvantage, but what I like about the Pentacam is the tear film doesn't influence the measurements at all. And sometimes with some RGP patients, when you get the SPK and tear film, you don't get quite as good data.
Absolutely, as well as even the initial capture data. You know, if they have a somewhat sloppy tear film, that does plague your data a little bit. Whereas, like I said, the Pentacam is immune to that.
Fantastic. Our next question is, how do you determine the amount of lens decentration that's acceptable when using the comparison maps?
I personally don't accept any amount of decentration. I believe that decentration in Ortho-K treatment is it's a recipe for potential problems. If you subscribe to the theoretical model that mid-peripheral plus is the single most important inhibitory factor for controlling myopia and the growth, the axial growth of the eye, and you have a decentered map, that means you're essentially delivering unequal dosages of your inhibitory treatment to that particular eye. And from my perspective, I believe that at least opens you up to seeing asymmetrical growth of the eye. I don't know if I'm not aware of any studies that have looked at this, other than the monkey studies that Earl Smith did intentionally doing that, where he specifically had half the eye occluded from the other half of the eye, and he clearly showed that you were able to get an eye to grow on one side much more than the other. So if in fact you have the potential for an eye to grow and you don't have proper centration of your treatment, I do believe that you're opening yourself up to possibly seeing asymmetrical growth of that eye. And what that would turn into would be irregular cylinder that would now be uncorrectable. You may actually induce uncorrectable optics at that point for that child later on in life. So more importantly than the vision quality, which would suffer from decentration, I think when you're looking at controlling myopic progression utilizing Ortho-K, I think you have to hold yourself to a much higher standard to make certain that the lens is not decentering at all from a treatment, standpoint.
Excellent. Here's a common question I see: how flat can you go? Is it 38 diopters?
No, it's not 38 diopters. I think that 38 diopters came from the days where you're utilizing pre-made lens designs, and it was found that once you got into 38 diopter corneas, things got very dicey and your treatments were really kind of sloppy and it just didn't work. I've certainly treated and gotten corneas to go considerably flatter than that with Ortho-K with very, very nice clean treatment zones. And I think that that's attributable to the fact that you can get a lens that aligns beautifully, it does not decenter, and it really treats exactly how it's supposed to treat, creating nice, equal tear film squeeze forces under the entire dimension of that rear surface of the lens. So I think if you're using any of the pre-programmed types of Ortho-K treatment approaches, you might have to have that sort of limitation. I personally believe, though, with Wave, I don't really see that that's as much of a big issue any longer, nor has it been for me for many, many years. And that really isn't the limitation. What you really want to look at things more like what's the size of the cornea, how big is the pupil, how big are the treatment zone size that you can effectively get onto that eye. What are the E values? How is this particular cornea flattening from apex to edge? How asymmetric it is. Those are much more important questions than using an absolute as 38 diopters or 36 diopters or whatever number as an absolute. Don't take the case on.
Excellent. I have a question about your case number 3 in the Wave Design profile. How do you know how much to alter the various control points? The lens design at the control points look very irregular to me.
That's way beyond what we can get into in this lecture.
That's probably a whole webinar, right?
So, sorry, guys. That's a several-hour webinar in itself.
All right. Let's see. Let's go here. Okay, the question was about that last case. Did you keep that patient who you diagnosed keratoconus? Did you keep that patient in the orthokeratology lenses, or did you switch them to something different?
No, at the time of the diagnosis, we had a very lengthy conversation. We talked about cross-linking. We talked about my concern over Ortho-K and the unknown, because we really don't have a lot of literature out there. There's been a couple of cases that that have been done for Keratoconus and Ortho-K to show it to be safe, but there's not a lot of data out there, and so we had a very lengthy conversation about that, and ultimately we decided to discontinue our Ortho-K and to put her into a traditional day-wearing lens again.
Okay, I have 2 questions here that kind of go together, so I'll read them both to you, and maybe you can answer them separately or together.
Sure.
What do you consider a thin cornea since the front surface with orthokeratology has been altered? And can the Pentacam data show you whether Ortho-K is strictly epithelial or is there stromal change?
Okay, to the first question, understand that the epithelium you're talking about, and yes, epithelial tissue centrally thins in Ortho-K. Epithelial tissue paracentrally thickens, but we're not talking on the order of like what happened in my third case. The epithelium, you're talking only about 55, 60 microns of thickness there. That's the entire epithelial layer. So that being the case, you get a cornea that's in the lower 400s. That's just a thin cornea. That has nothing to do with yeah, we did Ortho-K and now she has a thinner epithelium. To the second question, where you're talking about separating epithelial versus stromal thicknesses, thinnesses, I don't personally have any way on the Pentacam software where I can view them independently. The people at Oculus may know a little bit more about that and may have actually a better answer for that than me. I do not have access to any of that.
Yeah, the answer is on the current models of Pentacam, there isn't an epithelial thickness mapping. Stay tuned.
Got it. That's what I figured, but okay.
I've got one more excellent question for you. After the washout period, if you get a lot of cylinder, what should you do?
If you thoroughly washed out an eye and the topography looks the same now that it's washed out as it did prior to Ortho-K treatment, and now you have cylinder, but before you didn't, I would be very concerned as to where the cylinder came from. Now, if you're saying that, no, for some reason, the cornea didn't have a lot of cylinder at the beginning, but now all of a sudden you washed it out and it did, all I would say there is it's not washed out far enough, and the cylinder is still showing. Now, again, part of this may be tied up in exactly what I was commenting about decentration and measuring it up as cylinder. Decentered optics, which typically will manifest as the higher order aberration of coma, will manifest itself refractively behind the phoropter as cylinder. So is it true cylinder? Is it maybe just aberrant optics that may be coming in from some other source? So that would be my answer to all that. Now, as far as what do you do about that? Well, I don't know. You wash them out. So are you putting them back into Ortho-K? You're going to give them some glasses. You're putting them into some rigid lenses with toricity. You know, you would obviously you would just address it optically. Now, if you're telling me that you have a cylinder on the cornea and you're putting them back into Ortho-K, I would say now you need to address whatever cylinder is there so you can optically give them a result that they can see properly through. So I think I answered all the possible alternatives to that particular question.
Yes, that's an excellent comprehensive answer. I've got one final question for you, and that is, would you have fitted that patient, the keratoconic patient that you described in 2006, if you'd known that they were keratoconus at that time, if you had posterior elevation measurements? In other words, would you fit a keratocone with Ortho-K?
No. We sit here in the United States in a litigious society, and I think you're way out there in terms of liability. You just do not know what the implications are of Ortho-K and keratoconus. All you need is for some, you know, someone to come along and, you know, you've got, oh, well, you measured them first, you saw they have keratoconus, you put them into Ortho-K, and now they need a corneal transplant because their keratoconus advanced so rapidly, and it's all because of your Ortho-K treatment. So you know, I think you have to tread very, very carefully on stuff like that. And absolutely positively, if I had posterior elevation maps that showed anything back in 2006, no, I would not have fit her into Ortho-K. Like I said, there was nothing there clinically to indicate keratoconus, even like as a glint in my eye. You're talking about a relatively flat cornea, healthy, 17-year-old, normal boring corneas on the anterior surface. Yeah, God, you'd be hard pressed to say, oh, yeah, well, that sure looks like a keratoconic. And then to manifest, and really not all that much, in her 30s is a little unusual. So I grant you this is a little bit of an unusual case. And I don't know that the posterior measurements back in 2006 would have shown that she had anything unusual on the rear surface. Maybe she might have indicated that at that point the corneas were maybe in the low fives, you know, in terms of pachymetry measurements, and maybe that would have given me a reason to pause. Say, why does she have corneas that are only 510 microns, you know, thick? So that might have given me reason for pause and to watch her a little bit more closely. I don't know that I would have seen anything unusual on the back surface, but if I would have, no, I wouldn't have proceeded with Ortho-K.
Well, Dr. Mallet, this has been fantastic. I can't thank you enough for sharing your expertise with us. If anybody has any questions, we have our email address at Oculus, sales@oculususa.com. My email address is wtullo, Tullo, at oculususa.com. And again, Ken, what a fabulous job. Thank you so much. And I wish everyone a great night. Thank you.
Thank you very much, Bill. You guys all have a great night, and thanks for coming tonight.